Every organization does not do the blame, shame, punitive, and the use of errors as opportunity to learn more, to look for defaults in the systems, to try to improve. Medication error is all preventable, 100% preventable. I started with this idea that medicine used to be very simple because there are people saying, why now? Why now all of a sudden medication is important in the WHO agenda, top agenda, and all that. So before, medicine used to be simple, used to be ineffective and unsafe because they're simple. But now medications in the market, they compete. They are very complex, they are not safe, and they need more vigilance, and they're dangerous. Okay. For example, amiodarone, if it has to be approved now with the current system from regulatory, safety regulatory perspective, it will never be licensed, never. Maybe warfarin will never be licensed, but it has passed those days. So nowadays, this drug, before they are approved, they go through safety regulations. But still, they are not. You need to do more now. You need to do more monitoring, prevent errors. Okay. So this is very popular slide for any medicine medication safety presentation. You will see this, one of those. But from my perspective, it has becoming number 3 in USA. It was in 2000. It is still in 2000. Maybe now it is still the same. It's a medical error. So medical error means everything. Surgical deviations, falls, and medication. And medicine is usually the biggest part of medical errors. So medication error is part of medical errors, and it's the most busy part of medication error. Okay. Medication error, this is very latest from NHS. They realize that it causes burden to our resources. We don't notice in our settings because our beds are already paid in advance. You get 1 year budget. So if patient, one of the burden is length of stay, but our length of stay is already paid. So if bed is free or not free, that bed is already paid. But you have the consumables. Patient stays, extra complex patient may consume more consumables, and more efforts from doctors and nursing time to care. Doctors' time will be more utilized, and you may need more resources to try to manage that complications. So it is still a burden. Yeah, we shouldn't tolerate medication error because of the cost, because of the trust. Patient comes from home to hospital. We still have that trust that keep patient coming to the hospital, and that's why we employed. Imagine if patient stop visiting hospital, we won't have a job. They will start to reduce our numbers and all that. So we want to maintain that trust. Unfortunately, in Oman, maybe it's not very good because people leave Oman, they went for consultation, and believe me, most of the things that they receive care or therapy is sent to Oman. So it is an issue. Maybe this is one of the reasons they trust. So we cannot ignore it, neglect it. Yeah. If we have to discuss medication error, we have to first agree on principles that, number one, medication error is all preventable. 100% preventable. Why is that? Because there's a difference between medication error and adverse drug reactions. So the adverse drug reaction is related to the product. Medication error is related purely in the process. Don't blame a drug. Don't talk about the drug medication error. But we will understand on this part. So this part, if we can define very well what is medication error, what is adverse events, and all that, it will improve our reporting. It will improve our management. So, for example, usually the first thing that is being reported or concerned is the event. So you see that event. The event can be, it has to be adverse event, not the good events. So the bad events, they're the ones which causes, which will promote incident reporting, which will make concerns and all that. So they will, if you don't do anything on events, they will just be events, generic events. If you further analyze that event or try to understand what is causing that event, if a drug is culprit, a drug is responsible for that event, you call that adverse drug events. So change from adverse event to adverse drug event. In our incident report, I think the same with the ministry, so they have adverse incident, adverse event. In that down there is drug, there is a surgical, there is an instrument and all that. Then you have to, it has to be a drug event. But sometimes the adverse drug event doesn't come as a drug to you. It comes as an event. For example, a fall is an event. But you can report a fall because of ambulatory care is, nursing ambulatory care is not good. Or you can report a fall because a drug was introduced that causes dizziness. And with patients, like your dialysis patients are more risky. They are very fragile patients. They can have all the side effects you can have, the adverse drug. So if someone does that further investigation to understand the relationship between an event, most of the time you will find that a drug is responsible. It could be as simple as changing orientation, patient orientation, to space, to time, to all of this. But if you can do that, then that event, it's still an event. It's a drug event. You don't know if that event from the drug is medication error or it's adverse drug effect reaction. You still don't know. It's an event. At least you've done that part. So the difference between adverse drug reactions and the side effect. So the side effect is anything. It can be good and bad. Some side effects are very good. They are used to treat other disease. So that's why there's no side effect in all these incident reports. You don't report side effect. You can report if the side effects are the intolerated, the bad ones, then they convert as a drug, adverse drug reactions. Okay. Reaction because they are acute. There must be some event because we're talking about event. Adverse drug reaction at home, it can be at home tolerated, but you have to report it as reactions. So if you do analysis on adverse drug reactions and you feel that all the process involved is correct, that means you educate patient how to take, you exclude factors like renal factors, dialysis, that can lead to increased adverse reactions in terms of clearance. You adjust the dose, you did not cause more problem in blood viscosity and so on. If you analyze that and you're sure that my drug, my process, all my processes are fine, then you can blame the drug now. Then that's adverse drug reaction. What do you do with that? You can't change anything, you just have to report. So those number of reports, they go to the yellow sheet, spontaneous adverse reaction report, or you call it suspected adverse reaction form. It can be foam, it can be adverse drug reaction, or it can be adverse events. Either way, we have a yellow sheet scheme reporting system. The idea is just to report, then it goes for processing to Uppsala, to one of the center international body, where they take those events and try to do something called associations, Naronjo and other association, to see that is that event something already reported or it's a new thing. If it's a new, they call it signal, then they may ask further information. If it's already known, then if the number is a lot, then it can change the medicine reports in terms of, for example, phase 3 may report a side effect as uncommon. But with post-marketing, which is ADR, is called post-marketing surveillance, means that people report the adverse drug events. It can jump to common. It can jump to serious. It can go to precautions. It can go to caution. It can go to, after that, it can go to contraindication. It can go to black box warning. So all these, after the drug is released in the market, because before release, they have a very controlled environment. They watch this, so they document. But with time, whatever was caught in the real world, where patients are real now, they are not controlled patients, there may be something that that can happen, that they have to update their drug profile information. And especially if our population is different, because most of this drug comes from Western countries, so their population is different. So it's very important that we report the adverse drug reactions. But that's the end of it, you just report. Some of adverse drug reactions, some of them, the process is questionable. For example, if you give a drug, you haven't adjusted the dose according to renal or dialysis, and then the likelihood of reaction is more, or the side effect, then you can, then it's a medication error. Means that your process of selecting right patient, ensuring right dose, making safe, ensuring that there's no interaction that can lead to more side effects of another drug. If that is, everything is okay, then it will be considered to be adverse drug reaction. If your process is questionable, to prevent that event from happening, even though it's adverse drug reaction, then it's medication error. For example, a nurse will give diclofenac injection. For example, for renal you don't do that anymore. But for example, if a nurse or a doctor questions the patient allergy history and found that patient is not allergic, and if he gives that medicine and something happens, it is adverse drug reaction. The process was fine. But if you find out that reaction happens, but you found that the nursing did not do history of patient allergy history to rule out patient allergic to penicillin, to whatever drug, or that. If that was missing, then the same thing comes to medication error. So you have two reports now. So it will be reported as adverse drug reactions, and it will be reported as medication error. Means that there's a chance to improve that process of preventing another event to happen, similar event, by engaging patient or nursing to inform or to be more proactive. Okay, so if it's medication error, means 100% preventable. So that's the trick. Medication error is a preventable. That's the only trick you have to understand. Then it is reported as medication error, means that things can be improved. The process of storage, it could be as simple as drug is improperly stored, improperly reconstituted, improperly mixed, improperly, administer improperly. All those are process related. So those, for example, infusion-related reactions with vancomycin, with many drugs, phenytoin even, can cause reactions. But it could be due to the preparation. Maybe you need to observe a specific concentration, or the rate of infusion need to be followed to prevent infusion-related reaction. Even if it's something you did all that and then it happens, then an infusion-related reaction can be stopped. But if those practices of advanced monitoring are not available and patient there's an event from that reaction, then it's a medication error. For example, you have advanced drug reactions, initial dose, you can test the dose, you can go slowly, especially with the renal medication, first time use, eye injections, and we have rituximabs and probably antibiotics. Some antibiotic tests, but I'm saying some drugs you give slowly past. IVIG, for example. If that was not observed or practiced, then patient went to advanced drug reaction, infusion reactions, and you ignore to stop, then it can go into severe reactions. So it becomes medication error. But if you did everything you can, then it just because it becomes a drug related. Within the medication error, there is this part very interesting. See this part? It is not part of this big box. This is a big box. Why is that? It's because someone caught that event from happening, from occurring. Either it could be patient himself, empowered, understand his medicine, and they say, this is not my medicine. Or it could be you yourself, you realize that, or it could be anyone. So anything that is stopped, that did not reach patient, it becomes a near miss. As we just discussed before, near miss in terms of learning to improve, in terms of trying to understand the process, the opportunity to improve where could go wrong in future. Near miss are the best thing to handle for learning. Because in near miss you don't have to think about patient harm, and everybody is happy to discuss about near miss in a more honest way than if you did a harm to patient, especially if that harm is severe. So you will not just talk about it. Are you going to be affected? Yes, you will be affected because you did not intend to harm patient. So if this harm comes, you will not feel good. So near misses, the advantage of near misses are you can always be honest, you can identify the real cause, and you can prevent future causes. Swiss models is one of the, so what happened in our environment, hospital environment, healthcare environment, it is a very risky environment. You guys in renal dialysis is much riskier. Patients are fragile, patients are given, dialysis is causing confusion, patient disorientation, patients are on polypharmacy, lots of interaction, dose adjustments, patients have comorbidities, most of these patients are old, most of these patients need caregiver or support at home. So all those increases the chance of having medication adverse events, adverse drug events. So the good thing is your patients, although their medicine keep on changing, especially those critical medicine like potassium and spare binders. Otherwise, the good thing about your patient are chronic patient you're seeing every day. So it is opportunity to empower them through educating them. You have to make them partnership because it's not easy. It's advantage for you to use patients, to advocate safety, to prevent safety, to make it a near miss. This patient are your assets. the more you educate them, the investment, the time you spend to educate them, they're chronic patients. No, we don't have that opportunity, especially at Tertiary Hospital. They come and leave. You guys, you can slowly educate, and then until they become your partners to catch errors. So that's good. But they are very liable, fragile. So the Swiss model comes from the idea that a hospital environment is very risky environment. Either we accept that part, and that will be a normal accident theory part. A normal accident theory means you belong to an institute which it's very high risk. Something can go wrong very easily, especially in medication era. Too much process. Everybody is involved: nursing, pharmacy, doctors, patients, idara, inventory. So it's not easy. And within the nurse, there's a lot of process involved. So either we say we accept that, and that is normal accident theory, and then we try to improve our systems, like bringing machines and robots and all those things. Maybe we can stop there, but so the Swiss cheese model says accidents are normal, they can happen. We have a very risky environment, but those round, when they get aligned, an event happens. So those lose space, they are considered to be the latent errors. The errors that are lined, and if they are not identified and rectified, they will pass one day, a drug will pass through all those holes, and event will happen. Means that any medication, if an incident, you must, if you do root cause analysis, going back to look at what happened, what and why, you must find at least 10 reasons for that. You must. Because when you deal with medication, most of the time as a doctors, you deal with your mind. You rely on your memory. So that memory is being human and relying on memory, it's very risky. Any contributing factors, if they're not attended, for example, where is your computer to prescribe? Is it in the near patient noises? Is it in the corridors? Is it in your room where you don't disturb? All those will cause errors if you don't identify them as a threat or as contributing factors. You cannot insist to be human being. You can't. The more you're senior, the more likelihood to make errors. This is the study. It's because senior, they are, there is something called automaticity. They do things in automatic mode. It's like you driving home. First days you be careful, but after some time, you reach home and you don't even, how did I reach there? What happened? So it's not about senior, and when it comes to human errors, medication errors, it has nothing to do with seniority. It is about that automaticity. It means that you have to put in your process, you have to put safeguards, and don't only rely on seniors. It's just to identify that human mistakes that could be caused by lapses or by fatigue or by and if you are doing multitasking, disturbance, distraction, lighting, poor lighting, all those will contribute into different. It will contribute to something passed through that. So the normal accident theory belief in our system is very weak. It is inherited. But there is another way of nowadays to prevent errors. You cannot just say our hospital is risk, our processes are complex. You must do something about it. And the best thing to do is, of course, trying to improve your process and the system to create to create these safeguards or error-proof redundancies, but also to make the operators empowered, to involve them to participate in safety management, to involve each one of the hospital, to make each member of the hospital feel that we are in a high-risk environment, that accident can happen, inevitable. But if we improve our systems through incident reports, and if we continue to apply something called high reliability theory. High reliability theory means that even if, like the nuclear industries, there are industries that are very risky industries, but they survive better than us. Like nuclear, aeroplane, chemical industries, they are very risky, but what they did, high reliability organization, they went to make sure that each member of that organization is empowered enough to participate in managing safety in terms of identifying and solutions, and be proactive, and work as a team. All those are requirements. Now there is this requirements. Any WHO or any safety regulations requires hospital environment to adapt methods of high reliability organizations to prevent safety. So this is an example of how this model at prescribing error can lead to error. The latter error could be issues related to organizations, the lighting, the storage, where you store medicine, the lack of computers, the workload, management decision, staffing level, the culture of bureaucracy, speak out. Is it easy to speak out in this organization when you feel there's a threat? Will you speak out? Will you speak out to your high authorities? Is that something very easy? If not, then that will be, it will threaten. So those are latent conditions. They need to be identified and improved. Error-producing conditions like the busy world, the team, lack of supervision, the task, our system, our Shifa system of prescribing is not very safe. It did not go through safety standard checks. It did not go. And it's the most easy way to make mistake. It came from supermarket. I remember we used to have Medicom, and this, I was involved in those days. It comes from supermarket. The idea was to make it very easy for end users. So you will even be happy to hear someone from SQ with, they use other commercial systems from USA. They don't like it. They come and say, oh, the system is great. Yes, it's great because it's easy, friendly, and easy to use. But it lacks a lot of safeguards to prevent error. So our system, Shifa, it's easy to make mistake. So we are promoting errors. The most easy way to make mistake, just do continuous infusion. You will see how easy it is to make mistake. And for example, there's difference between strength and dose. So atenolol 50 milligram, that's the strength of the tablet. But it's there in the dose. So if a doctor, there's a database destruction and all these things, did multitasking, come back, see 50, just proceed. That 50 could go to pediatric. This is just a simple example. So unfortunately, we have to be the end users have to do a lot. It's unfair, but that's the situation. Active failures. Active failures, these are the failures that causes incident. These are the real failures. This is in the knife. There is a sharp end of the knife and the blunt end. So the sharp end is the one that will cause you injury. So anything that is active that causes errors are called active failures. And anything that is there, for example, lookalike, it's a latent error, but cell lookalike. If you identify lookalike drug or sound alike, and if you put measures to separate them, to segregate, and to educate others to be more vigilant. If you didn't do that, there will remain to be latent errors. Means that everybody will, it will just rotate. One day, one of the sister will make mistake with pharmacy, the other day someone, and they will end up, everybody one day in their life, in their work, they will make mistake. So everybody will, and when you make a mistake, you don't intend to make mistake. And you feel you are very stupid, especially if you're questioned. You will not like it, because you believe you are a professional, you are competent. You forget that you are also a human being, and that it may not be your fault. You're just in an environment that is careless, it's not been well designed. And then, so you will hate yourself. Your productivity will start to lose, especially if you have a culture of blame, shame culture. So the blame, shame culture or punitive culture. The punitive culture ignores the contributing factors, it ignores all these layers and keep the operator responsible for errors. And that person questioned himself. I'm sure I came home not to harm, I'm sure of that. So even that mindset is questioned now. Then you start to question yourself, what happened? Then you don't like it. So if the organization does not do the blame, shame, punitive, and the use of errors as opportunity to learn more, to look for defaults in the systems, to try to improve, then you're going to lose each time productivity of each staff. And that's empowerment will not happen. As we, this is interesting, it will remain like this, even if it's old. So in medication errors, there is a process of medication use. And that process, simplified, is ordering, reviewing, approving, consulting, prescribing, dispensing, distributing, verifying, administration, documentation. This is more physicians, this is more, could be physician, could be clinical, this is more pharmacy, this is more nursing. So what they found very interesting that the highest is nursing. And it's not because nursing are, it's because if a nursing error from nursing means it's a real error, an event happened in front of everybody. And nursing don't work in the offices, they work with the patient. So it is not easy to hide. If you hide it, someone else will catch it. So your number is more. For ordering, 33%. Why is that? Is because the physicians, their orders, they go through nursing, pharmacy, and all that. So one of them will report your errors. So your numbers will be high. The good thing about pharmacy is lowest, is because no one can catch us, especially in the dispensing, not the inpatient. Because if there's any errors in the prescription, when I say dispensing error, is not the prescription is wrong. Means I gave a wrong drug, ordered warfarin, I gave 4 milligram, I gave 5 milligram. The dispensing errors. Because patient will not realize this is a mistake. Usually patient like to build trust with healthcare. So they don't like to question their incompetencies. So they accept anything. They even confuse with, for example, warfarin. They can just say, oh, today they changed the dose, okay. So they accept that. But, plus it confuses. Even they come to emergency, the doctor will not associate. We have a lot of scenarios. Even as simple as rifampicin causes red urine, patient goes to, of course, if you don't educate patient will not be empowered, patient will not participate in the treatment to say that this red urine is normal, to differentiate. So patient will rush to emergency. He goes to emergency, there will be process of ruling rule out infection and all these things. And imagine that patient has actually blood before, especially renal patient. So it will go through that process, all the process. Maybe they will find something else, and it's actually the drug that causes it, for example. So we should empower patients to also participate in identifying errors and managing side effects, because some side effects are okay, they disappear within time. But you need to educate patients. You don't want patient to go home and make his own decisions, because you can't stop them from doing that. They will have to make their own decision. They take nitrates causing headache, they will just stop it. So it's better that you educate them that for the expected side effects. There's expected and unexpected. The expected one, they are the ones which are caught and they are in the literature. So you educate the expected one, you will see this, you will see that, don't worry, it will disappear, or do this, or don't postural hypotension, don't just stand up, sit, observe some measures. So if patient is involved, some side effect you can manage by educating. Some side effect you can ask, you can introduce another drug to prevent that side effect. Some side effects need emergency. Some side effects need to be reported in your next visit. It's not very urgent, but just report it. So these are most of the contributing factors related directly to staff that will cause medication error. Multitasking is the most important thing. When you deal with medicine, do not try to do two at a time. You go to, I know your computers are far away from preparation area, so that's the system default. This is easy to make mistake. Let us say ideally you have a computer near your preparation area, or at least print out of a prescription, then you go and prepare. Do one at a time. Finish one, and then the other one, and then the other one, and the other one. Inexperience is also true. Lots of double checking in the double check. See, the double check is good and not good. Double check could be good, but could also be the worst thing to do. So I'm sure your days there was emphasis on self-check. Self-check is the best. You do self-check, at least when you pick a drug, there's three-way checks. Check the drug name, check the labels, and check prescription. Self-check, self-check. With the introduction of double-check, self-check has really been very reluctant, self-check. So the double-check can also have this negative, how you process that I don't have to be very careful because someone else, I'm sure someone else will. Yeah. So it is there in the literature, it is not the best thing, but self-check is also double-check. So double-check, there's a difference between double-check is divided into self-check and cross-check. Independent double-check is different. This is used for high alert medication. That in the double-check, there's a lot of issue. Double-check, I mean the cross-check. So in the cross-check, usually if you work in a groups, unfortunately, not as a team, you usually want your partner, someone belongs to your group to be involved to check for your work. Why? It's because if they catch mistake, they will not expose you. Or you usually like to trust someone. So it's nothing to do with competency when you do double check. It is about identifying a human error that can happen due to contributing factors. So you can even ask a patient to double check, that would be great. It's okay. You're just trying to, there is ways now to educate patients to do a prompt questions. So there is a technique to involve patient to advocate for medication error. For example, you can educate patient to always ask question, and to always be interested. Like, are you sure this is my drug? Because of automaticity. Usually we, sometimes if we're busy and all that, we just give medicine without realizing. You know, in surgical, they have timeout. So in surgery, there's timeout. Timeout is good. In medicine, we pharmacy, we have to do timeout because it goes through many stations, because that's only our job. For nursing, you have other important jobs. So the timeout is very important. The timeout means I do the thing and then I stop, and then I go back, and then I check. It's like supermarket. If you go to supermarket, some people are very clever. They don't want to lose even 100 pesos because that's their profit. So what they do, they will do scanning, and then if supermarket belong to them, they will do that. They scan, and then they will start to count back. 1, 2, 3, 4, 5, 6. So that's timeout. It's very important. That's a self-check. This is a self-check. It's the most effective, believe me, self-check. But self-check can happen during the process, or it can happen at each stage. So self-check can mean I do everything, then before I give the patient, then I go back and check again. Or it can mean when I when I pick, when I calculate, when I measure, when I do all that, I need to, you do it while you're doing that. The double check for nursing, at least there's something called cognitive double check. The cognitive double check, it means you can't give patient 5 tablets 3 times. At least you don't have to know anything about that drug. Or at least the common sense. You should have a common sense. A patient is discharged with injection. Just a common sense, what's going on. Or you're in pediatric, an adult drug is prescribed. Or a drug that is very uncommon to see, it's in the prescription. So those are the most important cognitive. They don't require any further knowledge, just the common sense. Or you see a drug, antibiotic, 30 days. At least it's not routine, just question it. So distraction, interaction, the autopilot, you remember what we were saying, the autopilot. This is true with the experienced people, with the seniors. And it's dangerous because it's difficult to detect. They have trust themselves. They're used to this. Overconfidence. Fatigue. So the idea is when you do checks, it's not about checking your level of competency. It's not about an opportunity to fail someone. It's not about, and when you are asked to check, don't take advantage of trying to expose someone. It's purely because you're a human being, you can make mistake, especially if your systems are not safe. The design of our systems or process are not safe, or if your nursing ratio to patient is high, or if you have from DGMS medication that look like a lot of them, so it's not your fault. So that should be the only reason. How many minutes? 5 minutes?
It could be good.
Yes.
Half an hour we said.
Half an hour?
No, half an hour we said the lecture.
Okay. See, my idea of lectures, I try each lecture to talk about important message, especially the first slides. So anytime if I stop, it's okay now.
No problem.
Because there's 45 slides.
We concern also about your this one, about your. We brought you to give us more.
I just want to bring that, and I am sure you guys you have a lot to do. I think this will be my last slide because this concerns your patients. These patients are very high risk. This unit is very high risk. Medication you're using are very high risk. So you have all the reason to be medication error to happen, basically. So patient could develop allergies because of, even dialysis can introduce that allergies. Comorbidity we discussed. Communication barriers, it's very true. You have patients who are, actually most of dialysis patients are deprived patients. They didn't have opportunity to take care of their selves. So most of them are deprived, most of them are depressed. Self-care is reduced. They can't hear because of dialysis, there's fluids. Their mind orientation is not good. This changes every day. Within 1 week, there's this change in physiology, change. The blood, the psychological, the volume of distribution keep on changing. This medicine are affected by this. How much your volume is in the system. They can be culprit of your medicine. Adverse events can be more common in this patient. Multiple healthcare visits, they have comorbidities, so you are one of them. But they will think about dialysis, that you are the primary, you are the main. So it's very important that you also ask them whenever they buy medicine or take medicine to, because they are your partners, even if you ignore them, but they are going to be with you. So it's better to take advantage of it. Extreme age pregnancy, polypharmacy. Pregnancy is not very common. Polypharmacy is very popular. Discharge patients. Discharge patient for us, it means if you discharge a patient, there's a difference in their prescription. There's addition, there's deletion, there's changes, there is everything happens there. There is a new disease diagnosed, so it's discharge patients are important. And discharge patients, if they are not given time, empowered and educated, they become easy to make mistakes. And thank you very much for listening. I can continue. In the normal accident theory, they believe you have high risk environment. You better put constraints or forces and functions in your system. Means make it difficult for someone to make error. That's the main idea of normal accident theory. Means that, for example, in the Shifa, if it went through a simple standard quality safety standard check, if you take a Shifa to another country to look at safety, it will never exist. It will never exist. You can write paracetamol, same like you write potassium chloride, same. It cannot be. The process used to be handwriting is easier because you are attached to your memory. You have to remember, you cannot just write and you're... But with computers, it's very easy just to do, these additional factors that can contribute to your errors. Plus, the process involved in writing one prescription, maybe more than 20 processes. In handwriting, it's just 2 processes, pen, paper. So we have introduced new challenges, and if our system is not well designed to see this very important. There's something called human factor engineering. Human factor engineering means you study human behaviors, you understand human deficiencies. So when you design your process, make them difficult for that human, because he's a human, he's going to have lapses and slips, to make it difficult. Very good example I like to talk about this is outlets, oxygen patient outlets for gas. Old style was any tube, you can, if you want oxygen, you can give air, or it is compatible. Old system, very old system. Because engineers were involved in that process. They are better when it comes to improving systems. So they come up with a system that is a lock system. Oxygen tube will only fit in an oxygen outlet. Medical gas, from that day, there's 0 incident report. And before that, there's lots of incident report, patient receive oxygen instead of air. So it was 0. So that is called, I think they don't have here, but there's something called hierarchy of how to improve. There's a hierarchy, how to make your system better, perform better in terms of safety. So the least one is the personal approach, where you write warnings, you put personal approach is responsible. That's the least. Usually it doesn't work, and you lose people, and it causes conflict, and it causes more trouble. The top one is called forcing functions. The forcing functions means if I write warfarin, I can't proceed. INR must, the system will ask, do you have latest INR? If yes, then you can proceed. And if INR is above, then it stops you.
Yes, I have one comment. My name is Dr. Fadil. Yes, I agree with you totally that the SHIFA system needs to be upgraded, but at least we can ask the ministry about the medication part only. There's no big issues in the clinical part or the radiology or the lab, so we can make some suggestions to improve the quality of the prescription. So, for example, the interaction, if you write two highly interactive drugs, they give you a red line or any warning.
We used to have that, but they removed it.
Yes, because I remember myself in the transplant clinic, I have a patient for many years taking azathioprine, and at the time he came with high uric acid, and I decided to give him allopurinol, and I prescribed this for them. Both of them are contraindicated, and I wrote it already. And 1 minute before the patient is going out in the room, I remembered, and I removed it. I told myself if I did not remember, it would have been very. So if the system is giving you an alarm or a red line that these drugs are contraindicated or in high interaction, it would have helped me.
We have that system. It was there. It was expensive, around 200,000, but it was very useful. But as I said, it was in the wrong hands. The GMS, they like to be everywhere. They're supposed to do supply, but they're everywhere. They make decisions. So they fail to protect it. They fail to put the value. I was there in the meeting. They just asked me to be there, I don't know why. And they couldn't. And it was very bad that we lost that. But yes, but the other thing about the SHIFA, for example, the process issue. If our drop-down list, we requested that you can type C, and you have 20 medicine. So you are a doctor busy, you are busy, and you are not like now you are relaxed mode, busy mode, and you have to do a lot of things to select, and you may go wrong. So what we've asked is you have to type 3 letters, minimum 3 letters. So if you type 1 letter, you have 20. If you type 2 letters, you have 10. If you type 3 letters, you have 2. It's better for me to check 2 and not the 10. So that's the other thing. The other thing is in the SHIFA, there's something called Tolman letter. For example, you manage to have 2, dopamine, D-vitamin, because you are allowed to write 3 letters, D-O-P. So you have only 3. The other D-O's, they disappear. So it's good for you. But still, there is a safety practices to differentiate any letters that they're different. You put them in a tall manner, the capital letters basically. It's called Tolman lettering. So that will also help. There is another system of if it's high alert, put in red. So at least as a doctor, you know I'm dealing with high alert. For nursing, it's red. So there are simple things you can do apart from that alert things. So our system is very friendly, but unfortunately it has cost. Tamam. Thank you very much for your time. And, I hope we can have more of this. I know it's not your fault. All this is happening, but at least to understand, at least to understand your environment you're working with.
Sir, in the future, can we have a system like my cousin who's working in the United States have told me that with them, they cannot get, they don't have access to any medication without the doctor's order. Like for example, it's like the medications are locked.
Yeah.
It's locked. Then you have to enter the ID number of the patient, and it will come, and that's the only time you can get access to medication from the medication box or cabinet like that. from the doctor's order. So it's like entirely impossible for you to give a wrong medication to that patient.
See, this is called...
How can we have that system in here? Is it possible?
Where it is, this is one of the systems called electronic medication cabinets. We have in Royal Hospital in a new building, VIP. They came to our Royal Hospital, part of Diwani contract, because it's a Diwani they pay. So just like that, you know, they pick it, we understand it, we know what is it. We are now helping to make useful of it. So the system is, you are replacing your manual cupboards with electronic cupboards. Means a prescription has to be part of that cabinets. Then the nursing, even the timings. If you say 8 hourly, if we have a standard timings, and then if you go, it allows this allowance. There's something called time sensitivity. So some drugs are allowed to deviate 30 minutes, some 15 minutes, some 1 hour. So accordingly, if you exceed that, you can't access. Plus, as you said, if you access, first you patient, then a drug, then the administration, then it opens, and you can design it in a way that it can be a unit dose. In the USA, they have a unit dose. Pharmacy brings medicine in a unit supply. So nursing errors are, picking errors from nursing are zero. So the only errors will be the administration errors, or given to wrong patients. That's a different thing. But there's also system for that.